Today, who are answering?
Good evening, sir. I am Abhishek, sir. I'll be answering, sir.
Sir, and Ojas here, sir.
Sir, Yasser here.
And Yasser.
Yes,
Sir,
yes,
Amit,
Yes, sir.
Amit here.
Amit is answering. So 3 of you are answering today.
Sir,
Four,
four.
sir. Four.
4 of us, sir.
Okay, Yasser also and Amit.
Yes, sir.
Okay. So we just wait. Who else is joining? Hiren has joined. We wait for 5 minutes. I'll just see whether Maheshwari is joining.
Gite sir is not there, sir.
Gite sir is traveling, so he will join, but he may not be very active.
Okay, sir.
Pankaj is in the Canada, and he has got some 5 presentations from tomorrow onward.
Who, sir?
Pankaj Maheshwari.
Yes, sir.
So we just wait for 2 minutes, 3 minutes, and we'll start. Huddedar has joined. Make Dr. Huddedar co-host. So, Dr. Huddedar, Dr. Huddedar, can you hear me?
Yeah, I can hear you.
Yeah. So today we are going to have ward rounds. Means, usually they have got 2, 3, 4 patients, either pre-operatively, post-operatively, someone like, so in a very short, they will present the history, and some
Yes, sir.
investigations, and we will ask them quick questions,
Yes, sir.
like the different cases, and we'll see.
Yeah.
So we can then finish.
Yeah.
Okay. So
Yes,
you
sir.
are there, myself, Hiren is there,
Yes. Yeah.
Dr. Gite maybe
Tickets of panel
joining
like
in between.
Tasudi.
Yes, sir. We can start, sir.
Okay. Paras, you are ready? So we will do one thing. Abhishek,
Yes, sir.
like we, 4 of you, one after another. One person will be answering.
Okay, sir.
Yes, sir.
We will not be asking all 4 of you. So first, like you are there, then Yasir will be there, then Ojas will be there, and then Amit will be there, like that. So you
Yes,
decide.
sir.
So first we will start with whom? With you, we can start. And then, in
Yes, sir.
between we can, if anything is missing at the end of the clinic,
No
one
problem.
of you can answer. Fine?
Yes. Yes,
Okay.
sir.
Okay. So then we start with you.
Yes, sir.
Paras? Okay. Paras, you are starting. Paras?
Hello.
Yeah. Yeah, Paras.
Yes. Hello.
Yeah, Paras, we can hear you.
Yes. First case. Hello.
Yeah, we can hear you. Start.
So first case is a 68-year-old gentleman presented to us with lower urinary tract symptoms. The IPS score frequency is 3, urgency is 3, nocturia 3, precipitancy is 3, intermittency 2, straining 2, and sense of incomplete void 3. No comorbidities. On examination, there is grade 2 prostate enlargement, no non-tender, rectal mucosa is mobile. Investigation, hemoglobin is 13, TLC is 8900, creatinine is 1.1, PSA is 0.92. Ultrasound was suggestive of 62 gram prostate with pre-void of 450 and PVR of 160. Uroflowmetry, voided volume was 290 with Qmax of 9 ml per second, average flow of 3.2 ml per second. Patient underwent TOP. After 6 hours of surgery, patient presented in ward with this.
Yes. So Abhishek.
Yes, sir. Sir, so in this patient, sir, 6 hours after TURP, sir, the patient has presented with hematuria. Sir, it appears to be gross hematuria, sir. First, I would ascertain the vitals of the patient, whether he's vitally stable or not. Pulse, BP, I would want to see, sir. And at the same time, I would want to reserve blood at the same time, sir, of this patient. And sir, then I would like to assess whether the catheter, I would examine the patient, sir. I would do a per abdomen examination, see if there is any palpable bladder or not, sir.
Hey, question number 1, you are saying that you reserve blood. Now 62 grams of prostate, pre-operatively, you will not like to have a cross matching and reserve one blood? Or
Yes,
nowadays
sir.
you don't reserve blood for prostate, any size of prostate?
Sir, institution-wise protocol, sir, for a
No, what is the
smaller, for
protocol? What is the protocol? What is the guideline? Whether you will preserve blood or you will not preserve blood.
Abhishek, for this,
You-
why do you have to say institution protocol? Simple, prostate surgery and any surgery around the renal hilum. Will you reserve blood or not?
yes, sir.
Then
So in such case, don't say that I will cross-match the blood. Say that the blood is already cross-matched. If hemoglobin is dropped, I will transfuse. I will find out whether there is a need for the transfusion. Okay, fine. Now
Yes,
what
sir.
you'll do? What else?
So, sir, I will assess whether there is palpable bladder or not, sir, whether the catheter is draining or not, sir. And if irrigation is not on, sir, then irrigation I will put on. And sir, if if traction has been removed, sir, then I will reapply the traction, sir. And yeah, sir, if the catheter is not draining, sir, I will prepare for a bladder wash. And with an asepto syringe and normal saline, sir, I will give bladder washes so that the clots are evacuated. And
Abhishek,
sir, once
two questions. Abhishek, two
yes,
questions.
yes, sir.
Number one, after how many hours, if you apply traction, after how many hours you remove the traction?
Sir, normally it is said that 6 to 8 hours after TURP, sir, traction can be removed. But in our center, sir, next day morning it is removed, sir, the traction.
Okay, fine. So most of the time it is either 12 hours to 24 hours. People are
Yes,
keeping traction.
yes,
So
so
sir.
you can
Abhishek,
always say
you
that
have checked all the things which you said.
yeah,
You have checked the traction. You have checked that the catheter is draining. You have started giving the wash, and the color has become clear now.
Yes, sir.
So now what will you see now? Your color is clear now. What will you see? How can you make out whether it is arterial or venous blood?
Yes, sir. Sir, it can be made out whether it is arterial or venous. Because, sir, in the catheter, sir, without, I mean, after the urine is clear, sir, if there is pulsatile bleeding, sir, in the catheter tube, it is indicative of an arterial bleed, sir.
Very
And if
good.
it is a
So it will become clear, then it will come bloody again. Again, it will become clear. Again, it will become bloody.
yes, sir.
So
So if
that
it
is
is
one thing which will make you worried.
yes, sir. So if it is arterial bleed, I'll keep in my mind for a for to shift the patient in to the OT and fulgurate the bleeder at the back of my head. If it is
And
a venous
venous
bleed,
blood,
I will
if you give traction and it becomes clear, and then it remains clear only.
yes, sir. So that will be my
Very good.
mode of management.
so
And yes, sir.
Abhishek, how you give wash with the whenever there is a bleeding, which type of means you will prefer a septo syringe or you will use something else?
Sir, I have used asepto syringe in my practice, sir, during residency. So I would
So
prefer asepto
initially
syringe.
you will use a septo syringe, but suppose if
Yes,
you
sir.
push fluid inside and the returning
Yes, sir.
fluid is not returning back, what you will do?
Yes.
What
So
is the
yes, sir.
meaning
If
of
the
that and what you will do?
sir means the eye of the catheter is being occluded by a clot, sir, or a prostate chip, sir. So in that case, sir, I would give a wash under pressure, sir. I would like to use a lower lock syringe, sir. Syringe 50 ml syringe with a lower lock, and I will give wash under pressure, sir, and then assess.
And the bladder is full. Now what you will do?
Sir, bladder is full, then I will. Sir, I will try. Sir, I will give suction with the lower lock syringe, sir. Sometimes the clot comes into the lower lock syringe, sir.
So, like
What
you
else you
said,
can
that
do?
there is something stuck in the eye of the catheter, and
Yes, sir.
sometimes whatever you do, nothing happens. In that case, it is better to just remove
To
the catheter and change
change
it
the
into
catheter.
another.
Change the
Yes,
so
sir.
first, yeah. So you say if it is nothing is happening, first you will change the catheter because if you keep on giving wash, the
So
bladder
bladder
may
will keep
rupture.
filling. Yes, sir.
Fine. Suppose you have
Instead of
changed the
doing all
catheter.
this now, if nothing is happening, now what would you think next?
Sir, in spite of this, sir, nothing is happening and bleeding is continuing, sir. I would consider to take the patient in the OT and do a cystoscopy and
No,
fulguration of the
Abhishek.
bleed. Yes, sir.
Abhishek, how can you say that bleeding is continuing? It may be the
Hmm.
old clot. He might have bled 300, 400 cc. So just by the color, you
So
can't make
yes,
out
sir.
that he is
Yes, sir.
continuously bleeding.
So, what you should have said is, when I mean that nothing is happening, means with your catheter and washes, nothing is happening, and patient is in agony. So what sir said is correct. It could be the clot could have got organized. It doesn't mean that it is bleeding again. Of course, you will look for the site of bleeding again. But when the clot is organized, you have to shift the patient to the OT. You cannot keep
Right,
on
sir.
pushing more fluid.
Yes.
And one of the basic things that you should have said before giving a wash is you will empty the bladder. Remember, when you start giving the wash, first never put the fluid inside. Start emptying it.
Okay.
If you empty the bladder completely and then if it goes and comes, then that means that is the correct wash.
Okay.
So Abhishek,
Post-procedure.
when can you say that he is continuously bleeding?
Sir, when like it is seen in the first picture, sir, and that is continuing with the that is continuous throughout the tubing and the urine bag, sir, then I will say he's continuously bleeding and the vitals are also dropping, sir. That is also indication that the patient is
So,
continuously bleeding, sir.
first of all, you are giving wash and the wash is coming back. Hardly
Yes,
anything
sir.
is retaining inside. The clots are not coming, but there is continuously, every time you give wash, the blood, returning fluid is reddish in color.
Yes, sir.
That means there are chances that it is not the clot which is inside the bladder. Still,
Yes,
you
sir.
cannot be 100% sure, but there are no clots inside and he is continuously bleeding. That is why urine is red color. So how will you confirm it?
Sir, I will do a local ultrasound and see, sir, of the presence of clots in the bladder, sir. Whether there are
Fine.
any clots or he's continuously bleeding, sir.
So in such cases, what you will do?
So, sir, in such cases, sir, sir, I will try to assess the character of the bleed, sir. If it is pulsatile, then arterial, then I'll have to take the patient into the OT and fulgurate it. If it is venous, sir, I will reapply the traction if it has been removed and start the irrigation again, sir. Or, sir, I will give a bladder wash before that and continue till the washes are, sir, at least pink in color. And then I would start the irrigation for this patient, sir, and then assess after some time, sir.
So whether arterial or venous, if the bladder is full and nothing is happening, you have to take the patient to the
Yeah,
OT.
so then I have to take the patient to the OT, sir.
So
And
which
if
anesthesia
ultrasound
will give?
confirms, there are multiple clots or large clots more than 4 centimeters, then you have to take.
Yes, sir.
So Abhishek, which anesthesia will give?
Sir, spinal anesthesia only I will give, sir. Sir,
Fine.
because
And what are the instruments you'll keep ready?
sir, instruments I will keep ready, sir. Sir, cautery I will keep ready, sir. Bugby electrode I will keep ready. And
Bugby?
Bugby, what will happen with Bugby, man? You should have said roller ball.
yes, sir. Roller ball also. Yes, sir.
Sometimes you may not find the exact cause of bleeding or site of bleeding. Then you would
Yes,
just like to do roller of the fossa. But firstly, you will say cystoscopy and entire TUR instruments. Simple.
okay, sir.
You will keep that, but when you go inside, there is full of clots. Now you go inside, you see only clot.
So yes, sir. If there are full of clots, sir, then with the sheath, sir, I will apply a modified helix evacuator, and I will evacuate the clot, sir.
What do you
And
mean
then
modified helix evacuator? What is modified?
Is the positive pressure or negative? Negative pressure is active or passive?
sir, it is active, sir.
Alex?
The pressure, sir, in helix, sir, the sir, what helix made was a glass chamber and sir, two glass chamber connected to each other, which would connect to the which would connect to the sheath.
Helix
Action is active.
and Eurovac both have not got so much pressure. They are good for TUR chips. In such
So,
situation, you may need a
alternatively,
Tumi
syringe. Yes,
syringe.
alternatively, Tumi syringe I can use, sir.
In such
Alternatively,
situation,
ideally, you should use Tommy syringe only.
in this
Because there are so
situation,
many clots.
correct.
Otherwise, your fluid will go inside and the negative suction is not active. It is passive.
Once
So
you
you will
have
not be
lysed
able
the
to
major
evacuate.
clots, then if you use the evacuator, then it works. But in the initial stage, evacuator doesn't work.
Okay.
When clots are organized and large and the bladder is full, then you need the Tumi syringe.
Suppose with the Tommy syringe also everything is not coming. Now what you'll do?
Sir, if everything is not coming with the Tumi syringe, sir, I will Sir, use the sheath and I will try to drain the clots from the sheath itself, sir.
अरे बाबा
अरे बच-
नेगेटिव से नहीं आ रहा है तो शीट से कैसे आएगा?
कैसे
You
आएगा?
have you have got TURP instruments, na? What do you do?
So second question is, what are the different ways of removing the clots?
Sir, removing the clots.
Sai has answered. He has said you can use the loop. So
Yes.
you use your working element and mechanically lice the clots.
Yes.
So-
break the clots in small pieces.
Right.
Yeah. What else you can do? Many people, we put the suction.
Okay.
Okay.
Right.
So large bore suction and try to push. So again, it breaks the clot and
Yeah.
small pieces will start coming. So you
Right.
have to have all the three methods. You have to use suction also, you have to use Tommy syringe also in between, and you have to use many a times TURP set also. And you have to
Okay.
break the
Clots.
clots. Okay.
Any
So it
role
is-
of this one injection pause? Any role? Will you try?
Yes, sir.
Capillary
Injection.
Pause 1 gram IV stat.
Sir, usually we give, sir, but actual exact role, sir, I'm not sure whether it acts on it or not, sir.
Okay.
See, pause has got an effect on the
Capillary.
capillaries.
Yeah.
Yes, sir.
Bleeder.
But
Okay,
this
so if
is
it is a
yes,
large
sir.
bleeder, it doesn't have, but other peripheral capillary bleeding, it can stop.
Yes.
So
sir.
so after you remove the clots, everything is now clear. Still returning fluid, you are expecting of what color?
Sir, returning fluid at this point after clot evac, I will expect at least pink color, sir. Light pink color, sir, or clear.
If it is light pink color, what you will do?
Sir, if it is light pink color, sir, of course, after assessing of no active bleed, sir, I will give traction. I will
So
apply traction
first
to
of
this
all,
patient.
you will observe the fossa carefully, and
Yes.
you make. If I am in your place, I will coagulate again,
Okay.
because for the time being it might have stopped, but again it may bleed. So it is better. And if it is pinkish color, 100%. Most of the time we have seen that once you give wash, all the clots are out. Okay,
Right. Sir.
then it will be clear.
The
Clear
most
only.
important step now, Abhishek, is to empty the bladder completely. When the
Yes, sir.
fossa collapses, only that is the time when you can see some hidden bleeders at the bladder neck. Because when the
Yes,
fossa
sir.
is distended and the bladder is full, you may still miss the bleeder.
Yes.
So you
I
want to
will
observe
also-
areas. You want to observe areas where you have reached, but when it is distended, you cannot see them.
Yes,
So
sir.
that the trick is to see empty the fossa,
Yes,
empty
sir.
the bladder, and then look at an empty fossa, and then switch off the water and see if you see
Water,
any-
exactly. Yes,
Yeah.
sir. I will assess after switching off the irrigation also
Ah.
once.
And you need to observe the bladder neck nicely.
Yes, sir.
And normally at the 12 o'clock
Yes,
and
sir.
5 and 7 o'clock
Empty.
position.
So Abhishek,
Yes, sir.
now can you see these three
Yes, sir.
photographs?
Yes,
So
sir.
can you see the difference between the left one and the right one?
Yes, sir. The first image, sir, it appears to be frank hematuria, sir.
Left side. It is of dark color.
Yes, sir.
Dark,
It is.
na? First you
com-
should have told the difference between the color.
Color is obviously different. Yes,
Frank
sir.
hematuria तो दोनों भी है, लेकिन वो dark है, ये bright red है.
Right, sir. The third image is with wash, sir, with normal saline. So I am not sure whether it is hematuria only or whether it is collected blood inside.
So, but what is the difference between the first, second?
So
The first is a clotted with old blood.
yes, sir. And the second one appears to be, the second image appears to be with the irrigation on, sir.
No, it is
And
in the signaling tray. So it is again with the wash, basically.
Yeah.
Okay,
yes, sir.
they have given the wash and they have collected.
Yes, sir. So
And this may be arterial or it may be venous, but it is
Venous.
maybe. And it is little
yes,
bright red.
yes, sir.
Correct.
Yes.
Now patient is settled down. What you will do? You will keep the traction. Now what you'll do?
So yes, sir. Once the patient has settled down, sir, I would remove the traction again. I would observe the patient, sir, and I would observe the vitals and the urine output, irrigation, and the color of the output from the sir okay, tubing. And sir, after another 12 hours, sir, I would remove the traction.
So
And
you will sleep for 12 hours?
sir, yes, sir.
You will sleep for 12 hours.
Sir, no, sir.
So what you will do?
Sir, observe the patient, sir. The
So
color
how
of the
you
urine, sir,
observe?
vitals.
So
Sir,
one is the
vitals,
urine color, vitals, and second thing is?
urine color, vitals, palpable bladder, if any.
Exactly. Very good. Fine.
Yes,
And the
sir.
next day morning, will you like to send any investigations?
Sir, hemoglobin I would like to send of this patient, sir, next day morning.
CBC. Don't say hemoglobin. CBC. After
CBC,
doing all this
okay.
procedure, he might have developed some infection. WBC count will be high, 20,000. What you will do then? Initially, you will miss it because
Yes,
he is
sir.
already on antibiotics. He may not have
Yes,
fever
sir.
or other thing.
And also electrolytes, sir, I would want to send.
Electrolyte. Very good. Fine. Okay. Okay, Darji, aapko, if your experience, any other question?
No, sir. What I asked about this one pause also, and
Yeah.
second is breaking or breaking the clot with
Clots.
active current also. Yeah, cutting current can be used to break the clots. That is
Okay.
also possible.
Yeah. Okay. Thank you. Thank you. Chalo. Paras, next case.
Amit, you can
Ojas,
take it now.
who is answering? Ojas is answering.
Okay,
Amit,
sir.
Amit.
Amit
Yes,
is
sir.
answer. Okay.
Amit. Okay, Amit.
Ojas, you take after Amit.
Yes.
Yes,
Okay,
sir.
sir.
So a 62-year-old gentleman presented to us with lower urinary tract symptoms. Frequency 2, urgency 3, nocturia 3, precipitancy 3, 2, intermittency 2, straining 2, and sense of incomplete void 3. The patient is diabetic and hypertensive on medication. On examination, grade 2 prostate enlargement, non-tender, rectal mucosa is mobile. On investigation, hemoglobin is 13.6, creatinine is 0.9, PSA is 7.9. Sonography was suggestive of 50-gram prostate with pre-void of 350 ml and PVR of 110. Uroflowmetry voided volume was 290 ml. Qmax is 7.2. Average flow is 3 ml per second. Patient underwent TURP for the above complaint elsewhere and presented to us with the HPE report of.
Wait, don't show the
No,
histopathology.
don't show repair. Okay.
So Amit,
Amit
would
is
you have done
answering.
something different?
Amit,
Yes, sir. Patient's PSA was preoperatively high, so I would like to evaluate further.
How you will evaluate further?
Sir, I would like to do a free to total ratio. If
Okay.
it is less than 0.1, then I will further evaluate the patient with the doing MPMR of prostate. And
one second,
if
1 second.
yes,
Now you are talking before doing surgery or now?
sir, before surgery, sir.
But now,
Because
this
the
is the word round.
patient's PSA is in the gray area, sir.
No, sir. I asked him the question that would you have done anything differently? That's why he's answering.
Acha, okay. Okay, fine. But what I am asking you is now, yes, you would have done the MRI earlier. Fine.
Very good. Now, so tell me, Amit, what is between 4 and 10? What is the problem?
Sir, there is it is a gray area, sir. So in some case, it is might due to the cancer or some case might due to the chronic prostatitis. So we have to rule out
Correct. So one
by
way is to
doing-
do a free total ratio, and it should be applied to only between 4 and 10 PSA.
that. Yes.
Some people do free total ratio when PSA is 15 also. That is of no use.
Yes.
And the more the free the PSA, the patient more is free from prostate cancer. And secondly, you said that of course the sensitivity and specificity of test varies. So second best way to evaluate would have been a multiparametric MRI with a pyrite score.
Yes.
Okay, now suppose pyrite score came 3.
Yes.
What you will do? And
Pyrite 3 is equivocal response. So I would like to do the biopsy, sir.
Very good.
trust,
So
guidance.
why are you hesitating? So your answer should have been that he is a
Yes.
62-year-old man. He is
Yes.
not 82. Okay, he's
Yes.
62. And he has
Yes.
got only diabetes and hypertension. He doesn't have any major cardiac comorbidity. So definitely his survival is at least 10 years.
Yes, sir.
So, and he is a young man. He is still 62 only. He's not 82 or 92 or something. So definitely you would want to chase it, because if it is a organ confined disease, you will definitely want to
Yes.
cure him.
Yes.
Okay. Sir, you were saying something? Gaurang
Now
sir,
this patient has presented you with histopath report.
Yes, sir.
So Paras, show.
Histopathology confirmed prostatic adenocarcinoma, Gleason 4+4 8, grade group 4.
Were you expecting this? Amit,
Yes, sir. It can be possible in this case, sir, because the preoperative PSA was high, sir.
so now what is the stage of the disease? It is
Sir,
detected on
it is detected on the biopsy, sir, and
now
TURP,
what you do?
TURP, TURP.
yes, sir.
Means
TURP.
already
This is
TURP is done.
T1C, sir.
Correct. So not biopsy, TURP. It is detected on
T1C.
TURP.
Yes, sir.
Now, what will you tell the patient? He has come with this biopsy report and he has undergone TURP. PSA is 7.9 and it is Gleason's 8.
Yes, sir. I will explain the patient that he is suffering from the prostatic adenocarcinoma, and he will require further evaluation for the disease localization and what is the status of the disease, whether it is localized to the prostate or it is metastasized. So
How
according
will you
to
find
that,
out that now?
sir, in this case, Gleason is 4+4, so patient will be in the high risk in the risk stratification. So if and for
Amit,
the
remember, you
metastatic
have undergone
evaluation,
TURP.
yes, sir.
So now you want to do further workup. Which investigation you will choose? How many days post TURP?
Sir, I would,
3 months.
Which investigation you will do?
sir, after 4 weeks, I will like to do the MPMRI
Oh,
of
patient has
prostate
come
again.
now. Patient has come now. He has come 1 week after the TURP with the histopathology report. TURP was
Sir,
done
I would like to
1 week back,
wait.
and because he's got histopathology, he has come to Dr. Amit.
Yes, sir. I would like to wait for 3 more weeks and then do a MPMRI of prostate.
Why you
And
want to do MPMRI? Justify.
sir, the TURP mainly we dissect the central lobe, and I would like to assess the peripheral zone also
So
with
that
the
is fine.
MPMRI
I
process.
understand that peripheral zone has cancer, but
Yes.
why you have chosen multiparametric MRI? What does multiparametric MRI help in?
Sir, that will help in to assess the local disease, whether it is spread to any other organ or it
Morphologically, you
is.
want to see whether the borders are clear, seminal vesicles
Yes.
are clear, fat planes
Yes,
are
sir.
clear, whether he's still a candidate for radical prostatectomy.
Yes, sir.
Is it also helpful to detect metastasis?
Yes, sir. It is helpful to detect metastasis in the pelvic lymph node,
And
and
you can ask for skeletal screening window.
yes. Okay.
Is there any other investigation? Now patient says, sir, I don't want to wait for 4 weeks. I'm getting tensed. Whether my disease has spread to anywhere else, I want to know now. Is there any other test?
Yes, sir. PSMA PET scan.
Correct. So a whole body PSMA PET scan will tell you everything about the bones and lymph nodes and everything,
Yes.
and whether there is any metastasis. But you
Yes,
also want to know the local, whether there is any locally advanced CA prostate.
Yes, sir.
Therefore, multiparametric MRI will give you good morphological staging and local staging. And
Yes.
you are right that you should wait for 3 to 4 weeks. Okay. Paras, what was done?
Okay. So everything was clear.
MRI was suggestive of ill-defined T2 weighted image hypointensity in the peripheral zone on the either side of the mid gland without any diffusion on diffusion weighted imaging or early arterial advancement. Pyrad 1, abnormal T2 weighted hypointensity with transition zone at the base and mid gland adjacent to the TURP defect. These areas of hypointensity on ADC maps and early arterial enhancement on dynamic contrast enhancement MRI Pyrad 5.
Fine. So now if there are no metastases, what will you like to do, Amit?
Sir, patient is in the high risk category, so I would like to do a metastatic workup in form of, if the facility available, then I will do the PSMA PET scan, or if facility is not available, then I
Done,
Yes.
done, beta. You said na कि you want to do MRI and you want to do PET scan. So we have done
Yes,
it.
sir. Then patient, according to patient's age and patient is fit for surgery, and in this case, patient's life I am expecting patient's life expectancy more than 10 years. So I would like to offer him. Patient is high risk, so there is a.
You have
Why
mentioned
high risk?
fitness, but you should say cardiac fitness because he has got diabetes and blood pressure. So
Yes,
you
sir.
should do cardiac fitness, 2D echo, and then proceed.
Yes, sir.
Everything was done during the first surgery. Everything is fine.
Sir, I will explain the options available to the patient in form of surgery, radiation. These two options are available for this patient.
What you will like to do?
Sir, in this patient, I would like to do a radical prostatectomy with extended lymph node dissection, followed by patient is in the after the final biopsy report. I will further guide the patient according to the biopsy report, if adjuvant radiation is required or not.
Suppose patient says, I don't want surgery. So what type of radiotherapy you will offer him?
Sir, IGRT, IMRT plus VMET, sir.
Plus?
VMET, sir.
So which one you will offer? IGRT, IMRT, both are available.
Sir,
Image
sir,
guided
IGRT,
is
IMRT are same, sir.
correct. Intensity modulated or image guided?
In image guided, this is the image guided. Volumetric VMET and IMRT are different.
Correct. What is the head-to-head comparison between the
ADT.
two?
Yes, sir.
Between radiotherapy and radical prostatectomy, is there any head-to-head comparison?
Sir, in radical prostatectomy, we remove the whole the prostate, so there is a
Survival
there
rates
is,
are different or same for both?
sir, survival rates are same, sir, but complication and both are different, sir. In radical radiation, there is a chances of blood radiation cystitis and other.
But now with
Radi-
IMRT, IGRT, it is less, no?
Yes, sir.
Comparatively.
It is less, but in post of surveillance also in radiation treated patient, that biochemical recurrence we can declare after the 2 nanogram ml, while in after post radical prostatectomy, biochemical recurrence we can label after PSA rise more than 0.2, sir.
Correct. So in radiotherapy, you have to wait for the Nadir PSA.
Yes, sir.
Initially,
And
there will be a
after,
rise and then there will be a fall and then it will come to Nadir level. And then you have
yes,
to
sir.
follow the Nadir level.
Yes, sir. And in case of recurrence in the radical prostatectomy, we can offer the salvage radiotherapy, but in the patient treated with the radical radiation, the salvage surgery is very difficult.
Correct.
What is Rajesh's question? Can someone read it? Rajesh has asked some question.
Sir, he is
yes.
asking, respected teachers, once patient has presented with HPE report, if examiner asks whether we will start ADT after seeing the HPE report, how to answer that question, sir?
Yeah, Amit, tell us.
Sir, if we are planning to give a definite therapy in form of radiation or radical prostatectomy, then there is no need to start the ADT. If patient is in the before the
See, the answer is that normally, if we are, what you are saying is absolutely
there
right.
is
It is
no
not,
role of adjuvant
yeah, like a biopsy. Once you
neoadjuvant
take a
ADT.
biopsy, and once it comes positive, you're going to wait for 3 to 4 weeks, and then you're going for a surgery. Usually, we don't give. Correct?
Yes, sir. Yes,
Right?
sir.
So in this
Yes,
case
sir.
also, but if you're going to wait for a longer period of time, then you may start, you just give one dose. There are some centers which they like to give it, but then it may cause little fibrosis and lots of medicines, reaction in. So
Yes.
many centers, they don't prefer only. Fine.
Yes.
So what you will offer him, and what you will tell him that, okay, you are going to do radical prostatectomy. So what you will, with the Gleason score is 8 and the
Yes, sir.
period is 5.
Yes, sir.
So what you will explain to this patient? Even though it is MRI showing that it is organ confined, what you will tell patient?
Sir, I will explain the patient that after final biopsy report,
Patient is asking you, doctor, आप मेरा prostate निकाल देंगे बाद में मैं क्योर ना?
patient is in
You
the
are
high risk
already
category.
telling him that it is confined to the only to the organ. It is organ confined. You are telling this to the patient, and I am offering you this surgery so that I can remove the disease. This is what you will tell him. Correct?
Yes, sir.
Now he says, he asks you, okay, doctor, it will be after surgery, I'll be absolutely fine. Nah? I will not need anything. What will be your answer?
Additional radiation if margins are positive or
No,
patient.
beta. What you will tell him? What is the Gleason score?
The Gleason score 4 is 4+4, so patient is in the high risk category, sir.
So you'll explain him nah? That even
Yes,
though MRI is showing it is organ confined, even though it is the PSMA PET scan is not showing any other nodal or any other involvement, still
Yes, sir.
your malignancy is high risk. So there
High
are
risk.
chances that microscopic metastasis already might have taken place, which
Yes,
may
sir.
reflect after few months,
Yes,
because your Gleason score is high.
sir. Yes.
Okay, so I will have to, even though I remove everything, there are chances that after 3 months or 6 months, there may be some active lesion elsewhere in the body.
Yes.
So patient will say that, doctor, can you tell me whether, can you predict my life? How much, what will be the survival, depending on all this information that you have?
Sir, there are certain tables are there, but I exactly don't know the survival percentage.
Correct. So you can use the data and use in Partin's nomograms
Yes, sir.
and tell him that, with your Gleason score, with your PSA, and with the positivity, you can,
Yes, sir.
right.
Dr. Udedar, you want to ask any questions?
No, sir. No.
Okay, so the last thing, which type of surgery you will offering?
Sir, radical a prostatectomy with extended lymph node dissection, sir.
But how? Which method?
Sir,
Laparoscopic, open, or robotic?
depending on the facility available, sir.
You
Laparoscopy
want
and
to
robotic
you
are
want to
better.
tell him that which is the best one. What will you tell him?
The best one is robotic radical prostatectomy.
Why?
Sir, because the robotic radical prostatectomy has the advantage of uh, good suturing with advanced vision and
And in this case, already patient has undergone TURP.
URP. Yes, sir.
Correct?
Yes,
So
sir.
he is already
So,
fossa, everything is very wide. He must be having a small prostate, and it is very difficult. It might be little adherent to the surrounding structure.
yes,
Correct?
sir.
So in
Yes,
this
sir.
case, robotic will be definitely better than it has
Yes.
got an upper hand than all other method.
Yes, sir.
Fine?
Yes, sir.
Okay. Fine. So we'll go ahead. Third case. Paras. Who is answering? Tejas. Ojas,
Ojas,
sorry,
yes, sir.
Ojas. Fine.
Yes.
Later on abortion, presented to us with pus discharge per urethra and glands from the shunt site. Comorbidities, CML on imatinib. Hemoglobin is 9.6, TLC is 3900, creatinine is 0.9. Sonography of penis was done, which was suggestive of multiple echogenic foci with aspects in entire both corpora cavernosa with breach of tunica albuginea and involvement of spongiosum suggestive of infective etiology. So this was
You have got any other photograph?
so
Pre-op?
post management.
Pre-op you don't have, na?
No, sir. This is
Okay. Fine. So, Ojas,
Yes, sir.
what do you like to do now?
Sir, can I just see the first slide, please? The first slide. Aspiration, yeah. So the patient has
I'll tell you, they had tried to do something, okay?
yes, sir.
From glans penis to the corpora cavernosa.
Okay, sir.
And they had taken one stitch also to close it.
Okay.
And after few days, patient developed fever and swelling, and now there is a discharge per urethra. And he has got a full swelling right up to the groin and the scrotum.
So the patient, we'll have to start the patient on antibiotics first, and
He is already on a very good
Already.
antibiotic.
he will require drainage of the infections because it is
Will like
infected.
to do any? You will like to do any other investigation?
Read the sonography properly.
With SPC, corpora cavernosa, breach in tunica albuginea, involvement of spongiosum, ratio of infective etiology.
Air specs.
This looks like could be Fournier's gangrene.
So where is the Fournier's gangrene? It is intercorporeal or it is on the skin?
Actually, usually it will be a superficial skin infection. This is deep.
So why there are air pockets? After any instrumentation or after doing
gas gangrene.
then it will, you might have put the air inside, na? During the bath.
during aspiration.
Then, so but will you like to do any, or you directly want to this thing? Where are you going to make incision?
So we can do an MRI first of the perineum to see how much is the involvement, where is it involved,
Fine.
and then we can.
Fine. Okay. By show him. So MRI. What else you'll do?
Send the pus for culture. Do
Exactly.
an MRI.
And
Yes, sir.
you like to find out.
Yes, sir. It's going into the space is seen in both the corpora cavernosa. It is extending into the scrotum. It is confined by the collis fascia.
So what we'll do now? By report part, Paras. See, I'll tell you, this is one of the very, very rare cases we have come across. Because corporocavernosa infection is hardly you can see. Why?
Because
We have seen, you must have seen, you are in Lilavati, na?
it's a cochlear vein, sir. Cochlear.
Cochlear, sorry. So the people in Lilavati might have seen multiple, many cases of priapism and all these things. We do regularly wash also. But hardly this is the first case where there is an infection in the corpora cavernosa. Because it's very vascular otherwise.
Yes, sir.
And there is a continuous flow of the blood. So usually we don't see. With such a bad infection, this is the first time. Okay, so it is very new case for us also.
Yeah.
So how to treat? Fine.
Oh,
Just Hojadar ji, you want to comment anything?
No, sir, I will treat him as a corneal gangrene case with
Okay.
decompression of this one, open the airspace, this facial planes, and let the toxic material come out and cover
Yes.
with broad spectrum antibiotics and daily usual dressing.
Fine. We did the same thing, but we did little different. So Ojas, what you will do
Yes.
now?
So then, so regularly.
What is the meaning of incision and drainage?
Incision of a pus containing cavity and drainage of the infected material so as to facilitate healing. Source control, sir.
No. What is the meaning of drainage? When you incise, the pus is going to come out.
Dependent drainage.
What is the meaning of drainage?
Leaving it open.
So meaning of drainage means you will not allow it to close down before it starts healing. So
Yes,
there is
sir.
a continuous drainage. Either you put the pack inside, okay,
Use
or
of
you
packs.
put some drain inside, or you do the continuous irrigation. Understood? That is why we take a
Yes.
cruciate incision and we cut the edges in perianal abscess, ischiorectal fossa.
Ischiorectal abscess.
Right. So in the ischiorectal abscess, so that all the the skin, we don't make a single incision because we don't want it to heal from outside and inside the pus will remain.
Yes,
So in
sir.
this case also we thought the same thing. So how will you manage it?
So then regular assessment of the wound.
Where you will make a cut?
On the penile shaft and
So you'll take a circumcision incision or you will make a vertical incision?
vertical
the
incision,
pinoscrotal.
longitudinal incision, longitudinal incision, vertical incision
Where?
on the penile shaft, mid shaft.
Okay. And then what you will do?
And then drain the pus, leave it open.
From where? From where you will drain the pus? From the spongiosum, from the corpora, or from the subcute?
Subcute, sir.
Subcute. भाई MRI देखा हो उसको? MRI पढ़ो.
It's deep.
No, it is actually going to the corpora. So from the corpora, sir, corpora.
So you'll open up the corpora, na?
Yes, sir. But it will bleed.
So one side or two sides?
I don't know, sir. Both sides.
No, wide guess. अभी मेरे को भी नहीं मालूम था. But we logically we have thought something and done it. See, there is a communication between two. So if you do But
One
some
corpora.
irrigation or something, it will definitely. But here the pus is going to be so thick. Okay. At the same time, even the corpora body are going to get necros. So that
Yes,
is why we decided to make a cut on both the sides, give good wash and put the tube inside and do a continuous irrigation, means a regular wash. Paras, just show them. Make it a little big. Let them see.
okay.
See, the whole corpora was like a necros, you know,
Yes,
and
sir.
the thick. It was, so we try to remove as much as possible from both the sides. Okay,
Yes, sir.
fine. Show the next what we did after that. Okay, so we have put the two tubes. Can you see
Yes,
from
sir.
both the
And for
sides?
the
So
watch,
we are,
yeah.
we are giving regular wash.
Okay.
This was initial post-op. What is the final, Paras? This is the final result. Okay,
Very good
Ojas,
news, sir.
now patient
Yes,
has
sir.
gone home, everything is fine. And there was a there was a communication between the corpora and spongiosum. Means when we try to put this tube inside, it was coming out from urethra.
Okay.
So that is why we have put it not towards the distal end, we have put it to the proximal, that is near the pubic symphysis, both the tube. Okay.
Yes,
And,
sir.
yeah. Now how long you will keep the catheter?
So first allow the wound to heal.
Yes.
That would be the first thing. So after the entire wound is healed, then we can and the patient has recovered from the infection, and also on the other hand, uh, uh, if in the meantime also ask about the history, whether as in whether there are other issues which would help prevent him from voiding apart from the CML. So any other uh, that would be one. And
There was a pus coming out for urethra, and there was a communication, a big communication between the spongiosum, urethra, and corpora cavernosa. We have given
yes, sir.
wash. We have seen that everything is clear. Edema has decreased. Patient has responded very well. Gone home. He's on a good antibiotic. He's on a perurethral catheter. Now, when you want to remove it?
So after the wound is entirely healed, after that we'll remove the catheter, do a retro RGU plus a MC
Pericatheter.
voidings, and assess the urethra, and then if there is some other, again there is a communication, then in that case you like to reinsert the catheter and plan for a definitive repair. So first do an RGU plus MCU, sir.
MCU for anyway.
Mainly a
RGU, I
retrograde
can
urethroplasty.
understand.
RG only, retrograde urethroplasty, because you want to see
But
the anterior urethra. That's it.
But
Yes, sir.
you can say in this case safely that you like to keep it at least for 4 to 6 weeks.
6
Keep
weeks.
it 4 to 6 weeks. Let everything heal up, everything very nicely. Like you have done urethroplasty or something, and there is an infection. So you treat it, and then whatever you are saying, you can do it and can remove the police catheter. Now, how will you manage this case? Everything is fine. Now he's passing urine well.
Yes, sir. So, yeah. So the age of the patient, age was yeah, okay. So this patient will
Now,
have further.
Himanshu has asked a question whether we like to put the perurethral catheter or whether you like to do something else. Of course, one of the thing is you can do a suprapubic because he is passing, but we wanted that to heal and corpora, we wanted to compress. So the only way of doing it was to put the catheter and do it. As I told you, this is a totally a different case. Something.
Very
Not
rare case.
difficult. But what Himanshu is asking is a valid question. We can do a suprapubic. Fine. Okay. So now everything is fine. What you are expecting in this patient, he will be potent or important?
So he will have corporal fibrosis. So he will be important because of the infection. And we saw there
Yeah.
will be corporal fibrosis. He will have issues with erection.
So now
Definitely.
what you do?
Then inquire about the sexual history and whether he's still sexually active, whether he desires.
Of course, he's a very young guy, man.
Okay. Okay. So in that case, if there are corporal fibrosis, he would ideally need a penile prosthesis.
Is it easy to put a penile prosthesis in fibrosis?
No, sir. It will be difficult to get the planes because in this
So
case
what
it will be
you
all.
do? Of course, all of you don't know this. Even a few years back, even I didn't know much. Even though I was putting implant, but Dr. Rupin Shah explained me. I had a difficulty, similar case, but not. It was a priapism and fibrosis. Okay. So in that case, you have to ask the patient to use a pump, the special pump that you are getting for the erection. Let him use for 6 months to almost 1 year. By that, you will reduce the fibrosis. And after that, if you try to put implant, the success rate are very high.
No.
Okay. Otherwise,
Yes.
you will not be able to dilate that fibrous corpora cavernosa. You will again perforate urethra, or you can go subacute, and you will not be able to put implant. So this is a
Yes.
practical problem. Fine.
Okay. Yes, sir.
Okay. Fine. Good. You are thinking logically. That's very good thing. Okay. Paras, I think he has got some internet connectivity problem.
Hello. Hello.
Yeah, Paras, can you? Yeah. Case 4. So he's answering now.
Me, sir. Yeah, sir.
Yeah. Yes, sir.
A 52-year-old gentleman underwent kidney transplant, ABO compatible, discharged with stable vital with Foley's catheter and drain removal on post-op days 6 and 7 with serum creatinine of 0.9. Patient is hypertensive and is on medication with well control of blood pressure. Presented with penile and suprapubic swelling on post-operated day 20. On investigation, the hemoglobin is 9.8, TLC is 12,900, creatinine has increased to 2.2. The picture of the patient is given on the side.
Yes. Yes, sir.
Yes, sir. So
What do you
on
like
the
to do?
picture, I will first like to do the ultrasonography, sir. USG
First
of
of
the
all, tell
scrotum
me.
and
No,
the
first of all,
penile
tell me
region.
what you are
The
anticipating.
counts in the CBC are on the higher side. Is 12.9 K plus the creatinine has also gone high, so it's likely an infective collection, sir.
Have you asked him about the urine output?
No, sir. Before that, I would like to ask about the other parameters like urine output and
So Paras, what was any effect on the urine output?
Patient was having difficulty to void due to penile edema. So patient was having overflow dribbling. With there is decrease in urine output
decrease in
since the
urine.
swelling has increased.
Okay,
So
sir.
so what you are anticipating if the urine output has decreased and the swelling is increased?
So the two things are there. So I will like to have the Doppler of the kidney as well. Plus for the swelling of the penile and scrotum region, I would like to have the USG of
So
the.
why there is a swelling? See, have you seen transplant patients regularly,
Yes, sir.
post-operatively? Huh?
Yes, sir. Seen.
Have you seen any case like this earlier?
Sir, seen, but not in the transplant case only.
No, transplant I'm asking.
No, sir.
Local infection I can understand. But what are
Local
the
infection.
causes of local infection in this case?
Could be,
The
sir.
only thing is a wound infection.
Yes, sir. Could be wound infection. Could be, but the wound looks still healthy. The scar looks healthy, except there is a blackish scar we can see in the inguinal region, sir.
What are the things you expect in a post-transplant? What complications can happen?
First, in the we have the early post-op and the late post-op. In the early post-op, we can have the wound infection, wound descents, after that, the graft failure, sir, we can have.
Bleeding,
And
Baba. Bleeding.
Bleeding, yes, sir. As the
Then post-op, late.
late we can have, sir, this graft rejection we can have. We can have the urinoma and the
Graft rejection तो nephrology का हो गया. तुम urology बोलो ना भाई.
urology का, sir, urinoma we can have. We can have
Urinoma and what else?
organized
What else?
hematoma. Hematoma,
What
sir.
else? Any seals?
Lympho.
Sir, lymphatics. After cutting the lymphatics, we can have the lymphocele also, sir.
Correct.
Okay, fine. Okay, bye. Show them. Paras, go ahead. Paras, beta, go ahead.
But ultrasound and color Doppler of the transplanted kidney was normal.
Okay.
There was a collection in the kidney bed extending to the inguinal, suprapubic, and scrotum region. So we decided to do an MRI, urography. In this transplant, DJ stent was not there.
So there seems to be, sir, and collection in the lower part of the pelvis, sir.
See the
With
urography properly, Babu. He is giving you so many hints. First hint they gave you was that urine output was less. Second hint they gave you creatinine in that region. Third hint they have given you that there is a swelling. Fourth hint
No
they are
DJ
giving you
stent.
that they have done a urography. Look
And
at
there
the
is no
urography.
DJ stent.
If we start with the kidney only, sir, the corticomedullary differentiation is okay, sir. As the pelvic ileal system, I can also make, but down once we go the ureter. In the ureter, we can see, sir, it's not continuous towards the
Correct.
bladder,
So
sir.
you say, now I am
It's
not
a-
able to trace the ureter nicely to the bladder.
Towards the bladder, yes, sir.
It's a
And you can see the
dehiscence.
leakage. You can see the contrast going
Look at the
out.
leakage.
Yes, sir. Plus the this dense
And
density
everything
of,
is getting collected in scrotum. Can you see it?
yes, sir. The
Yeah.
density of the pelvic collection and the scrotal is same, sir. Intensity, sorry, sir.
See, this is a ward round, beta. In ward round, we are not going into the details. We just show and you say, you see, what is the important finding that you have to see.
Yes,
So
sir.
in this, you can see there is a leak, and that
Leak,
leak
sir.
is getting accumulated everywhere. No?
Yes,
So now
sir.
what you do?
So this is unlikely urinary leak, sir. So because the patient's counts are on the higher side, so first I will like to put in drain. I will like to drain the collection. So
You like
my
to drain the collection.
yes, sir.
Before that, you like to do something else also.
Just I will advise for the scrotal support and catheterize the patient.
Say
Arey Baba, first you
catheterization,
want
na,
to
yaar.
Yes, sir.
first you want to take care, na? You're a urologist.
Yes, sir.
What do you want to do first? You want to see that the leakage stops.
Yes, sir. So I will
If
put
you
the
just drain
catheter.
it, is it going to solve the problem? Is
No,
just draining the scrotum going to solve the problem?
no, sir.
What is the
So-
solution for the problem?
So we have to just put the catheter so that we can prevent the
Arey
leakage from
Baba,
the
either you will divert the urine by doing a PCN or you will do a DJ stenting attempt.
DJ stenting. Yes, sir.
Just putting catheter, how it is going to take care of the problem? Contrast is leaking out from the ureter.
Yes, sir.
Do you think
So-
that DJ stenting is going to be easy?
It will be so difficult because in this
Look
case,
at
First
the
of all, you have
position of the
done-
ureter.
Yes, sir.
Look,
So
first
there
of
is
all, it is
randomization.
abnormal position. Ureteric orifice is at an abnormal position. Second thing,
Yes.
it is already leaking. So if you put something, it will go out.
Out. Yes,
And
sir.
in such a case, you may disrupt the ureter. Will you
Yes, sir. So,
like to put a digestant?
sir, better diversion will be PCN only, sir.
Yeah.
See, no.
Yes, sir.
Okay, fine. So what you did, Paras, show them.
We just put a Foley catheter and the swelling gradually reduced and patient underwent a catheter-free trial after 14 days. Patient is doing fine.
So we were lucky in this case. Okay.
Yes, sir.
Then just by putting a catheter, it started draining and the leak stopped. It must be a very small leak. But otherwise, whatever answer you're given, that is the right answer. Put the catheter, put the PCN, wait for some time. Okay. After
Yes,
that,
sir.
you can do nephrostogram. And if it is showing leak, you can either put anti-grade DJ or go inside and do. So now in this case, what you'll do, if you have to do the anastomosis, what type of anastomosis you'll do?
Don't know, sir. About the ureter, sir.
Yeah. You will again do your uretrovesical anastomosis, or you like to do ureteric anastomosis?
Sir, if I can get the length, good length, then I can do the ureterostomy. If I am not able to
No,
get
you
an
have to
adequate,
good length. Huh? The leakage is at the bladder junction. Huh? So you can.
Usually in transplant ureters, you get good length.
So,
then I
so
will
the
do
idea will be,
ureterostomy.
forget about the bladder now and just do it with the ureter. Okay.
Yes. So I
Because
will
otherwise, there are chances of leakage and all are much more.
more. Okay, sir.
Compared to the bladder, the ureter has got a very good circulation, and it will be a good anastomosis. Fine. Okay. So, shall we go to the next one? Case 5. Who is answering now?
Sir, I will take this one, sir.
अभिषेक तो हमेशा बोलते रहता है, I want these two fellow, last two people.
Okay, sir. Okay,
Huh?
sir.
Amit will answer and Yasser will answer.
Okay, sir.
Yes, sir.
And then we will ask you in between. Abhishek, don't
No
worry.
problem, sir. No problem.
A 66-year-old A 66-year-old gentleman underwent open radical cystectomy with ileal conduit for muscle-invasive bladder cancer. Patient was stable and orally allowed on post-op day 5.
No.
Tolerated.
You tell them okay, what happened on the table.
What happened?
But that rectal injury was there, no?
During the time of surgery, there was a small rectal injury, which was repaired primarily. Patient was stable and was orally allowed on post-op day 5 and tolerated well. Drain was removed on post-op day 8 after patient passed feces and flatus, and the output was nil. On post-op day 15, patient presented with progressive pain in lower abdomen with gross edema of scrotum and penis with fecal discharge per urethra on post-op day 18 with functional ileal conduit. On examination, there was swelling in the right iliac fossa extending to the hypogastric, penile, and scrotal region with tenderness with fecal discharge on squeezing of penis. Hemoglobin is 9.7. The TLC is increased to 19,900. Creatinine is 1.3. PCT is 1.2 and CRP of patient is 212.
Yes. Yes, sir.
Yes, sir.
What you will do? The management was okay? You would
Sir,
have done everything differently?
No, sir. The management is okay. Post URB to MIBC open radical cystectomy with the conduit had been done, sir. So this patient
No,
has
no,
the
no. After the rectal injury, whatever they have done, is it okay?
uh, he said that the rectal injury was minor. So if the primary repair was done on table, that's okay, sir.
So someone may say that you should have done ileostomy or colostomy. Colostomy may not be very useful because we are already done in one more anastomosis proximal to that. Correct? So
Yes, sir.
ileostomy.
Yes, sir.
Sorry. So anyway, that is during the surgery, the decision
Yes.
should have taken place.
Yes,
But
sir.
we thought that we will put the rectal tube inside, flatus tube, and we'll fix it up across the. It was a fresh, clean cut. We could suture in 3 layer,
Yes, sir.
and so we didn't do colostomy or we didn't do ileostomy. But now this is a situation.
So now this is answer feco urethral this rectourethral fistula only. So in this case, I will, because the counts are on the higher side and the creatinine has grown up. So I will like to proceed with the investigation, confirm my diagnosis, whether it is an urethral or an rectourethral fistula, or the sides, whether it is an single, it's the leakage is coming from the single side and the multiple sides. And then I will go for the exploratory laparotomy and cleaning the abdomen, giving washes, proper washes, and taking the colostomy.
Colostomy or ileostomy?
Sir,
Proximal colostomy is sufficient.
colostomy.
But before
Colostomy.
colostomy, there is again another anastomosis.
So I will check if there is because this is the post of 15th. So
You think it is very easy to open up such case where you have done uretero, you have made the ileal conduit will be adherent. Then there are
yes,
two
sir.
ureters inside these, and then you have done there is a fecal material inside, huh?
Yes, it
And
will
you
be,
have
sir,
done
very
ileal
difficult.
anastomosis, so many anastomosis. You think that it is going to be easy thing?
No, sir. So this will be difficult, but because it's in fecal peritonitis, so
So what you will do then?
I will have to go, sir. Go inside, give the washes, and take the colostomy out, sir.
Colostomy or ileum?
Sir, I will go for the colostomy only, divergent colostomy. If the ileal this anastomosis is okay, sir. If there is some leak or if I suspect some edematous anastomosis still after the 2 weeks of the anastomosis, then I will like to take the ileostomy on. So that decision will be taken on table only, sir.
So the most important thing is, if you ask me, I will do the ileal anastomosis, ileostomy before this. I don't want to take any chances because I have done so much of, laparotomy and so much of trauma. There are chances that I may again injure the ileal anastomosis.
Okay, sir.
Best thing is just go inside, bring out the ileum just before the
This
anastomosis.
anastomosis.
Because post-operatively, you don't know. You do colostomy, now nothing comes. Patient develops distension of abdomen. What you will do?
Then
This is the
again,
only
this.
chance patient has.
Yes, sir.
So show the report for us.
So this is an okay. So, sir, this is in contrast enhanced CT. The findings which the first thing is that the liver and the other organs and the renal system looks normal. The bowel, the small bowel especially, is distended. So I can make a large collection in the right side pelvis. It is occupying the lumbar as well as part of the hypogastric and the pelvic area, sir. So
now
I cannot makes a leak on this. I would have, if patient would have been tolerating, I would like to go for the oral contrast also to see where from the leakage is coming, sir. So in this case, I can make only the this has CT has helped me only to make the size of this collection and to make it that the collection is very large, sir.
okay. So what you will do now?
But since after pushing the pins, the fecal matter is coming out, so this is in fecal peritonitis. I will go for the laparotomy on this.
Fine. So as we said, okay.
Yes, sir.
Bye. Paras, what we did.
So we
Anyway,
took the patient
Paras,
for laparotomy.
yeah,
There
was
was
given, and then I think ये किया ना
sigmoid,
transverse
divergent
colostomy.
sigmoid colostomy was given.
Okay, fine. Chal, Paras, last case. Last case, na?
हाँ sir. 2 cases. Wait. A 22-year-old gentleman underwent a road traffic accident due to slippage of the two-wheeler. Presented to emergency with no signs of head injury. On examination, the airway was intact, breathing and ventilation, respiratory rate was 18 per minute, SpO2 was 98 on room air, circulation and blood pressure, BP was 98/58, pulse rate was 130 beats per minute, USG fast, suggestive of right hepatorenal collection with a perinephric collection, chest X-ray and pelvic X-ray, no abnormalities detected. Disability and GCS 15, GCS was 15 with no focal neurological deficit. On examination of per abdomen, tenderness was present in right hypochondrium and right flank region. Genitalia were normal, no meatal bleed or bladder lump palpable, no hematuria post catheterization. Patient responded well to the initial fluid resuscitation. Post primary survey and stabilization, the blood pressure was 112/76, pulse rate was 100 per minute, SpO2 was 99%, and the GCS was 15/50. What next?
Yes. What will do now?
CBC and
Sir, I would like to do
CBC, blood grouping cross match. Again, continue the resuscitation. Keep assessing the vitals and major abdomen. Also look for any. Also auscultate the chest for any rib fractures or any other issues. Also, chest X-ray is normal, right? Chest X-ray is normal. Chest X-ray is normal. Yeah. So first check the CBC and everything, and accordingly send for blood group cross match. And so based on the further hemodynamic stability, we will take the further decision. If the patient's hemodynamic is stable, then I like to investigate the patient with a CT contrast and a CT. Creat will also be checked. I would like to do a CT scan, contrast and a CT scan abdomen plus pelvis.
So what do you like to do? CECT?
So CCT abdomen plus pelvis. CCT.
Yeah.
If the creat is normal,
Because
CCT
you want to
abdomen
rule
pelvis.
out any other organ damage also.
Yes, sir. Not just urography. I want to see the liver also.
Yes.
I want to
Very
see the
good.
liver also.
Sure. Paras, what was the finding?
So CECT, I will read out the CT finding. On CECT, other organ was normal. There is a 11th rib fracture on the right side, just adjacent to the right kidney. The right kidney appears hypodense with no post-contrast enhancement up to 3 hours with hyperdense perinephric collection noted with thickness of about 3 mm. Right renal artery is visualized up to 13 mm from the origin, distal to which there is the right renal artery is not visualized. No active contrast extravasation or pseudoaneurysm is seen. Renal injury score according to trauma grade is 5.
Grade 5.
Sir, it should be 4, sir.
4, yeah, it should be 4. No, it's not completely shattered kidney, so grade 4 it will be.
There is a contrast cutoff from 13 mm from the aorta, sir. So
So it is grade 4. So it's
it
not
should be
involving
grade
the
4, sir.
grade 4. So if it is grade 4 and if the patient is hemodynamically stable and hemoglobin is not deteriorating, 12-hourly HP monitoring and vital monitoring, if the patient remains stable and there are no other adjacent organ injuries, then we can still do conservative management. However, if there is a drop in the hemoglobin hemodynamic instability, then we might have to consider the patient for operative management. Initially, it would be conservative management, sir.
But in this case, there is no contrast uptake. It might be aversion of renal artery with.
But there is no
Contained
active
hematoma.
extravasation seal. There is no active extravasation. That's what it is, sir. So we can still do conservative management.
You don't want to save this kidney?
Yes, sir. So we would counsel the
Prashant is
patient.
saying, Prashant is saying interventional radiology and stenting. Is it a good option?
Can be tried, sir. Yes, sir.
Absolutely, because there is no evidence as of now on imaging that the artery is completely avulsed.
Yes, sir. So and then, sir, if this kidney is conserved, sir, without any, if this kidney supposedly non-functioning is conserved, sir, so there may be complications in the later period, sir. So of that also we should be careful, sir.
So in this case, there are two options. Either you conserve or you go inside. If you conserve, do you think this kidney is going to work?
No, sir, it is more than 3 hours.
More than
Yes,
3
sir.
hours.
So more than 3-4 hours, sir, this kidney is unlikely to function, sir, even with the
So
revascularization.
then why you want to conserve?
Sir, if the patient is hemodynamically stable, sir, then we can discuss the discuss the complications of conserving this kidney with the patient, sir. Means what all complications can occur if this kidney is left in situ, sir.
So you like to remove this kidney or you are going to keep this kidney inside?
Sir, I would want to remove this kidney, sir.
Yeah, so you can say that immediately you may not go inside because already 3
yes,
hours
sir.
are over and
Yeah.
you are not going to do the anastomosis and going to save this kidney. I understand. But as soon as possible, once the patient is stable, as soon as possible, you should go inside and you must remove this kidney
Yes.
because there is a large hematoma all around it.
So might
Correct.
get infected later on. Patient may develop page kidney, hypertension, calculus, chronic pyelonephritis. Sir, all these complications. So because of these complications,
Yeah.
I would want
So
to remove the kidney.
I'll just brief you what happened in this patient. He was conserved. After 1 month, he developed fever. He developed abscess. They did the degestanting. They put the perinephric drain. The large amount of pus was drained, and ultimately we had to remove this kidney. Okay. So in
Yes, sir.
such cases, it is not advisable. Once you know, sooner or later you will have to go inside and you will have to remove this kidney. Okay.
Yes, sir.
Yes.
Okay. Dr. Udedar, you want to ask any question?
No, sir. No.
Paras, I think we will stop here. Huh?
Okay.
Excellent
Okay.
cases, sir. Very good discussion.
Yeah.
Yes. Because next time, if we have got some cases, let Dr. Gite and Maheshwari be there.
Yes, sir.
Fine. Okay.
Okay, sir.
Sir.
Good
Yes,
night.
sir.
Good night.
Good night,
Good night,
Udedar,
sir.
sir.
Good
Thank
night.
you,
Good
teacher.
night.
Thank you,
Good
teachers.
night.
Good night, sir.
Good night,
Thank you,
everybody.
teacher. Good night.
Good night.
Good night.